Well, good evening, everybody. Welcome to CAEP National Grand Rounds. I'm Howard Ovens, coming to you from Toronto, home of the Toronto Raptors. And on behalf of myself and my co-chair, Kylie Booth, I want to welcome you to a two-part Grand Round on COVID-19. This evening, part one will reflect on the lessons from the spring and first wave and look ahead to what those lessons mean for the coming fall and winter respiratory virus season. At this moment, I hope we've all enjoyed a brief respite over the summer, as we've had generally low number of COVID cases nationally, and good weather has allowed us to enjoy some outdoor activities, recreation, catching up with family and friends, gathering on patios, all relatively safely. But as the days shorten, we are already starting to see case numbers rise again in much of the country. And we will face increasing challenges as schools reopen and weather gradually forces us back indoors. We have some advantages socially at this time compared with last winter. We know a lot more about the virus and the benefits of public masking, good ventilation, and we're less concerned now than we were about fomites and surfaces as major sources of transmission. On the other hand, we also have pandemic fatigue to contend with, not to mention the politicization of the public health response, as well as myths, rumors, and conspiracy theories to confuse and distract many people. In our emergency departments, we have confidence that droplet contact precautions are broadly effective at protecting us. And overall, I think national PPE stockpiles have grown and supply chains have stabilized. But we won't be able to rely on low ED volumes forever or broad surgical shutdowns to ensure our flow and protect us from crowding. We have to look ahead to the potential confusion multiple simultaneous respiratory viruses may present. Through all of this, I think CAEP has been a faithful partner and advocate for all of us, including, among other things, producing a long list of important position statements and clinical guidance documents rapidly, and creating these virtual town halls and rounds to educate and connect us all. We're lucky to have CAEP available to us in this challenging time. Tonight, to save time, we're going to keep our introductions brief, so as all of our speakers have posted their biographies online at the CAEP website. But we're very lucky to have these experienced ED leaders here to share their experience and thoughts with us. To introduce our speakers, here's my colleague and friend, Kylie Booth, Chief of the Emergency Department in Collingwood, Ontario, and a member of our Ontario Provincial Emergency Services Advisory Committee. Kylie?
Good evening, everyone. Before COVID hit, Howard and I were scheduled to moderate the Ottawa CAEP 2020 track on flow and efficiency. And we were pretty excited that we were going to provide a dynamic lineup of speakers, a focus on efficiency strategies and innovations from the front lines. Of course, then COVID hit. So tonight, we look forward to bringing you an excellent lineup of speakers who will share their experiences from the pandemic thus far, and hopefully frame a really interesting and fruitful conversation on pandemic team management, safety, wellness, flow, and innovation, and ultimately how we as emergency physicians can lead our healthcare system to deliver high quality care to communities across Canada. Tonight's program will focus on two community experiences from Ontario and Quebec from two dynamic leaders whose departments were very hard hit. Dr. Mark Afilalo has been the Director of Emergency Department at Jewish General Hospital since 1986, and over his lengthy tenure, he's led his department through many challenges. Emergency medicine has been Dr. Afilalo's passion, and together with his fellow leaders in Quebec, he's fought for our specialty of emergency medicine to be recognized in Quebec. Next, Dr. Eric Latovsky, Chief of the Emergency Department at Trillium Health Partners in Mississauga, Ontario, a program that serves over 275,000 patient visits per year with over 110 emergency physicians. Trillium Health Partners is the largest emergency medicine program in our country. And then finally, we'll invite Dr. Kieran Moore, emergency physician by training and current medical officer of health for KFL&A Public Health. Dr. Moore is professor of emergency medicine, family medicine, and public health sciences at Queen's University. and he'll provide us a unique dual perspective that we really hope will unite our front lines of emergency medicine with our public health department. As you may know, tonight is the first of two parts, lessons from wave one, and we hope that you'll mark your calendars for part two on October 7th, when we'll continue our program with a focus then on flow and deficiency. So it's my pleasure to introduce Dr. Mark Afilalo. Take it away.
Thank you so much, Kylie. Thank you, Howard. I'm going to share my slides with you. If you give me 1 second. Okay, so it's a real pleasure to be here, to be among our big family of Canadian emergency physicians in this very difficult time. I'm going to try and stay on the major point of what happened to us. How did we react at the Jewish General Hospital in Quebec? And I'll be very glad to answer any questions that you may have during the question period. What did we really face as a first wave? We were the first designated hospital in Quebec to handle half of Quebec. We had many admissions from other hospitals, both in our wards and ICU. In terms of emergency department, we have seen an average of about 50 COVID positive or rule out cases per day. We started seeing some cases in February, but not that many, maybe one a day. But everything started like with you in March, April, May were our biggest month, averaging 13 to 1,600 patients a day, with a rate of COVID positive patient from 12% in May to 22% in April. That was definitely the hardest month for us. I wanted also to show that even since June and August to now, we're seeing about the same number of rule-out COVID patients. There are very few, if any, COVID positive. We may see one a day in our emergency, very few COVID admission. So it is quite a different time. In terms of our ED structure, I was asked to maybe bring the points I believe have helped us the most face this pandemic. First, to tell you, if you were to ask, did we do well, in the first wave, my answer will be an absolute yes, based mainly on the fact that we met our number one objective, that is safety for all the staff and patients. That was by far our number one priority. And we met it well beyond expectation, as transmission in the ED during the first wave was zero. No transmission from staff to staff, no transmission from patient to staff or staff to patient. I think what helped us the most is our culture. We have a culture of a very unified, proactive, committed, hands-on physician group, a real and total co-management with nursing. There's nothing we do without our nursing partners, including all our policies, protocol, strong multidisciplinary teamwork with our colleagues from other domain in the emerge. And we insisted of having a very clear and frequent communication with all the staff. To maybe cite what we found to be the most useful one was the daily Zoom meetings with all the staff, where I've never seen such a huge attendance, much larger than our usual department meetings. So it was very nice to see. The ED design also, I promised myself not to mention any of my colleagues. I apologize to them. They are so involved and so important to everything we do, but I've decided not to mention anyone by name, but I know who they are. The ED design was a major plus for us. It was designed with a mind of maybe seeing more infectious disease cases, but never a real pandemic as the one we have lived. We are using we have 3 pods, stretcher pods. We're using 2 of them for COVID patients or rollouts. This is about 32 individual cubicles, 10 of them being negative pressure. And to tell you how good was our design and our designer architect, the ventilation system, he thought about making sure that the partitions between cubicles were not just going to the false ceiling, but were going to the cement roof. So really making an excellent system. 5 recess bays, all of them negative pressure. So we were left with 2 cold areas, one a pod of 16 cubicle and RAS and fast track in the ambulatory area. I would not get tired of mentioning how important and vital the ED staff is. Without them, I wouldn't be presenting today for sure. So I'm presenting on their behalf. Extremely committed, they bought in, they were very proactive in participating. They have agreed to base to work according to the schedule that was based on the contingency plan that I'll talk about in a second. One thing we have done that ended up being excellent was the creation of a new shift, day and evening, 7 days a week, called the COVID doctor. That was one of the COVID leader that would be in the emergency and will be a fantastic resource for everyone on most issues related to COVID. The contingency plan also was a major achievement by a team of my colleagues. We have done it early, very early. We have done it in an extensive way. And it was done to show, depending on the number of patients we may see on a daily basis, and knowing what is the capacity of our emergency department, what will be the absolute needed length of stay to prevent any crowding and to allow us to stay at 80% occupancy. And at the same time, to define how many doctors, nurses, etc., we would need depending on which scenario comes and hit us. This superb work by my colleagues prompted the hospital to do their own contingency plan of staffing, of capacity for COVID, both on the ward and in the ICU, as well as redefine the new consultation and admission policy that will allow us to meet the targeted length of stay depending on the scenario. I'm very happy to report that they did very well too. The hospital has built a capacity of COVID ward bed of 240 beds and 60 ICU beds that were ready to roll according to the demand from the emergency department and the rest of the province. Maximally, what we have used is respectively 170 and 25. So it is really what I call a disaster plan of planning for the worst and but wishing for the best. We never had to go above those numbers. The hospital also agreed to do a new consultation and admission policy that was put the consultation answer time to 30 minutes and admission to an hour. And also very pleased to report that it went extremely well. I mean, we almost had consultants waiting for consult, not only because they wanted to help, but also the fact that most the cold patient activities decreased significantly. We had much more physicians in the hospital that were ready to help the emerge and the wards in a fantastic way. In terms of policies and protocol, that maybe where we spent most of the time, they were written by us. We had a leader also in that section, extremely detailed, very accessible. And we've done them through a strong collaboration. But I bolded, I think it's the only bolded word I have in my presentation, a negotiated collaboration with ID and infection control and prevention, because it was extremely important for us that those policies and protocol be tailored to our needs of a department seeing a huge number of patients, very differentiated with potentially COVID positive patients. So it went very well, and we were able to present them and be accepted to the hospital as joint protocol. We were very often ahead of public health in Quebec. When public health declared Wuhan as the only high-risk city or country, we elected to put all of China. When public health elected to add 2 European countries, we elected to add 11. And mainly we were ahead in making, thanks to our CEO, mask mandatory in for all emerge staff, but also for all emerge patients, visitors, etc. Our system is simple. We have a screening nurse that screened all the patients. In total, 120. Our pre-COVID volume was 250, so you can see the huge drop of number of patients. The 50 hot patients were directed, 3 directly to recess, but the vast majority, 47, to the garage. That was another innovation that we couldn't have functioned without. And from the garage, we had a team of a full-time physician, day, evening, night, nurse, unit agent in full PPE. And they were able to process those patients by discharging right away home or to a testing unit the next day. 18 of those patients and 29 were brought to our hot COVID pods, making, if you want, a total admission of 13 per day, 11 from the hot pods and 2 recess from the recess patients. Other key points that help us, PPE, again, a dedicated, superb, excellent, motivated physician who made it his mandate, and brilliantly so, of defending our department in terms of the best PPE we should have and we got, working with the hospital and other groups. Being a data-driven department, we have created many COVID reports, but the main one is what we call the flow markers for COVID. that is an online live report that anyone can access anytime, that will not only show all the patients with all their characteristics, etc., but will also show the obstacle, the delays in terms of consultations, in terms of admission. Simulation also was a key element, not only to train our own people and our nurses, but also to have other departments join us as medicine, OBGYN, ICU, and many subjects were dealt with in terms of cardiac arrest, intubation, and other. Research-wise, very fertile in this COVID time. We're actively involved in a huge genetic proteomic research project with the hospital, where we have added the clinical part that will make a really good open source for research. The Canadian Registry is also a fantastic initiative, as well as having had approval from ethics of our hospital to conduct a research project on the data we are collecting already. This is just our first simulation tabletop. If you see the date here, February 17, so quite early. It's incredible how we learned how much we weren't prepared, but collectively was fantastic. We had people from EMS, from security, medicine, ICU, surgery, labs, infection control, and infectious disease. And I think it's the activity that cemented everything else after. Is seeing all of us that is going to hit us very soon, and we better do our stuff together and doing jointly. And that was a very good exercise. Our hospital did well in phase one, very well, I would say. They really gave full priority to the COVID patient by their capacity contingency plan. IPC was superb. There's not one day where we won't exchange and work together. Infectious disease department was stellar. There were daily COVID leaders meeting at 2 o'clock, where any issue that would pertain to anyone will be discussed and resolved. Nursing was exemplary, as everyone, we're all suffering nursing shortages, how they were able to provide coverage for the beds we had to open. The 170 COVID bed is really to their, I commend them for that. The doctors also on the admitting wards and the ICU and the consultant, we felt a very different practice from them. They were very happy to work much harder, and they were very happy consultants from all services to help on the wards and in the emerge. We had a full testing lab 24/7, a very proactive PPE procurement policy from the hospital. I talked about the consultant, and we are finishing a hospital command center. In terms of ED innovation, I may say things that may be a bit controversial, but crowding is our number one problem, has been forever. I fully agree with CAEP and most other that mentioned that the bed block is our number one problem, and it is. I'm just wondering if how much we can wait for the governments and hospitals to solve their capacity issue, and how much is it possible when we consider the budget issues. I believe more and more that emergency physicians can and should take control of measures that will help us more deal with crowding. And I didn't mention it, but I'm sure you understand that I'm talking about crowding, because being crowded and having to face a pandemic is strike one and two, then we're out. And innovation we're proposing are telehealth triage, telehealth virtual room, waiting room, telehealth to discharge patients earlier with the safe follow-up. Intensive home care program with our geriatric patients who are taking a lot of resources and then getting even sicker once they're in the hospital. It is possible. It can be done safely and allow us to decrease their length of stay in emerge. And the hospital at home is really what mainly in the US people are concentrating on, because we could do it. Not every admission in the hospital, mainly in the geriatric group, requires an acute care bed, and services can be given home. I don't want to forget mentioning our own responsibility in terms of ED staff to maximize our performance a lot through harmonization of care, patient order set, choosing wisely. The challenges of the first wave in Quebec was the awful long-term care tragedy, the worst we ever had in Quebec. 20 to 40% of the ED visits were from long-term care areas. 80 to 90% of the mortality was from this group. Very sad. Also, the fact that there's not strong evidence-based knowledge on most of the issues, and you have different school of thought. And as Howard said, the politicization by the Ministry of Health is an issue. I would like to be at their place. Well-being is an issue I want to talk a few seconds about, because it is affecting more and more our staff. It was very hard to work during the first wave, but we are continuing to work hard during the pause, and we are all worried about the second one. Many of our people lived in hotels, not to transmit to their families, live in trailers, live in basement of their house. I also like very much Howard's expression of pandemic fatigue. It's increasing every day, every week. The challenge of the second wave, and that's my last slide, is we have no idea when, how bad. My two biggest worries are what will be the cold patient number. We did well the first phase, but we had almost all the hospital to us. Now we are back to almost pre-COVID volumes, and we collectively don't want to decrease the other services, but how can the capacity of the ED and the hospital meet these new realities? We're going to get hit by the flu, gastroenteritis, although I believe that with everything we learned through the phase one and PPE, like Australia reported, they always had flu before us, and they had quite a better picture than last year, thanks to our awareness in regard to infectious diseases. I will just conclude by again restating that we did well because of our team. They deserve all the credit. Without them, I would make this presentation. And now it's my pleasure to pass the baton to a very good friend, Eric Litovsky. Eric?
Merci beaucoup, Mark. That was great. First of all, I want to thank Howard and Carly for inviting me tonight. And the second thing that I want to do is I want to put in a plug for CAEP tonight. I've been a proud member of CAEP for over 40 years, for longer than some of you have even been alive. And I'm going to evoke my best JFK by saying, for those of you who are not CAEP members, ask not what CAEP does for you, but what you can do for CAEP. I know what CAEP does for us. CAEP's our national voice. It's the organization that glues us all together from coast to coast. It's the organization that advocates for frontline emerge stocks. And even more importantly, it's the organization that advocates for patients who need access to urgent and emergent care. And, more than anything else, it creates a community for us. So for those of you who are CAEP members, thank you for being members. And for those of you who are not, I'd urge you to become a CAEP member and contribute to the national organization and contribute to this specialty, which I think is still young and developing and needs your assistance and help, especially at this time where the organization is strained financially. So join CAEP. Just to give you some way of background, we have 3 sites at Trillium Health Partners. We have our Credit Valley Emergency Department, which pre-COVID saw 150,000 patients a year. Our Mississauga site, which pre-COVID was seeing 100,000 patients a year. And we were running an urgent care center at the Queensway Health Center, which was seeing about 65,000 patients a year. So pre-COVID, we were seeing 280,000 patients a year with 110 emerge docs. We're located mostly in the Peel region, one of the hot spots in Ontario. At the peak of COVID, we had approximately 122, 125 patients in the hospital at both sites, and about 25 ICU patients at our peak. So we were busy. Let me categorize my remarks into 4 areas. I'd like to talk about what worked well. I'd like to talk about what didn't work well. I'd like to talk about lessons that we learned and some other general observations. And finally, some remarks about just going forward. Well, what worked well? Well, what worked really well was how quickly we revamped our total operations. I mean, literally overnight. I think the day was March 12th. We completely converted our total operations. We converted our 2,500 square foot ambulance bay into a patient care zone. A third of the ambulance bay was dedicated to triage and registration. A third was dedicated to a waiting area. And a third was dedicated to a COVID assessment area, with the whole goal of trying to protect the inner core of the hospital for patients who might be febrile and have respiratory symptoms. That worked well. Patients would come in, they'd see an emerge doc out in the bay, and they would leave the bay as soon as they were tested. We restructured the rest of the zones in the department for different patient populations, and we completely revamped all our physician shifts to accommodate the changes in flow. And I just have to say, I'm always astounded by how resilient and adaptable emerge physicians are, especially when the going gets tough, the tough get going. I'm constantly amazed at how resilient we are at making changes. And throughout this whole process, just natural leaders just emerged who took charge and just stepped up to the plate, and I can't thank them enough. Second thing that worked well was the education that we did. Weekly sim sessions at both sites to upskill the emerge docs on protected code blues, airway management, oxygen delivery systems. Many of these sim sessions, just as at the Jewish General, were multidisciplinary. We worked closely with anesthesia, we worked closely with pediatrics, we worked closely with medicine. And again, with regards to education, just natural leaders stepped up to the plate and put up their hands and said, I'll run these sim sessions on a weekly basis. And they just talk off with it at both sites. And again, it meant so much to me. The airway management teams was something that I strongly pushed for in early March and came to fruition near the end of March. These were airway management teams at both sites consisting of an anesthetist, a respiratory therapist, and a critical care nurse, 24/7, who came down to manage the airways 24/7 at both sites. And I think it took a lot of pressure and was a great relief to the emerge docs while they were getting upskilled on airway management in a protected environment. What also worked well was the response of my colleagues as part of the Human Resource Contingency Plan. Very early in March, the hospital did a hospital-wide contingency plan, thinking about the worst possible scenario. Worst possible scenario was that emerged docs would get sick and that we would lose human resource capacity. The call went out to the entire medical staff. How many of you would be willing to work in the emergency department if push came to the shove and we reached that kind of critical situation where emerged docs were getting sick and we needed other docs from other specialties, other programs to come assist us. And there were about 40 docs from across the institution that put up their hands and said, I'd be happy to work in emerge. These were pathologists, radiologists, pediatricians, internists, surgeons, obstetricians, folks who put up their hands and said, I may not be very good, but if I had an emerge doc I could present cases to, I'd be happy to do it. And we ran upskilling sessions for these docs, not trying to turn them into emerge docs, but we ran simulation sessions for them twice or three times a week for 6 weeks. We gave sessions on ACLS, ECG interpretation, how to put on, how to don and doff, common ER medications, rapid fire approaches to the top 20 ER presentations. They all came in and participated. And I have to tell you how heartwarming it was to see that kind of response from my colleagues. What also worked well was our goals of care team. Realizing that the emergency department is a terrible place to try to discuss end of life issues, especially during COVID, during a pandemic, especially when visitors were restricted from coming in. We introduced a goal of care team at each site that consisted of social workers, our discharge nurses, and the whole point of this team was to be able to take over from the emerge doc to have that difficult discussion conversation with patients as they came into the emergency department, short of breath, or febrile, or whatever, to have that conversation with folks if they didn't have advanced directives. These are difficult conversations to have. In general, emerge docs don't have the time it takes to have that difficult conversation, and these discharge nurses and social workers were able to spend 30 minutes, 45 minutes, sometimes an hour with patients and calling their families to discuss, what would life look like if they got intubated and put on a ventilator, et cetera, et cetera. So I thought that worked really well, and I was proud of that innovation that we introduced. What didn't work well? Well, I think in general, we were generally unprepared despite the early warning signs from Asia. I think in general, we weren't as, I think we were caught flat-footed and weren't as prepared as we could have. So I don't think it's going to be a surprise to anyone on this call that in terms of PPE, I think there was a lot of confusion. I think the procurement and distribution of PPE wasn't organized as well as it could have been. The quality of some of the PPE was questionable sometimes. Some days we would receive masks that may have been appropriate or good enough from an infection control point of view, but couldn't stick on your nose because they were just too flimsy. And that was pretty demoralizing to the staff to be given equipment that was, inadequate or not meeting, our standards. The lack of transparency about PPE supplies was demoralizing. I think that the transparency locally, provincially, nationally, and compounding with all the publicity about the need to conserve and recycle N95s, it just created a lot of panic and a lot of anxiety among the emerge physicians. So I think the whole PPE issue didn't work as well as it could have. Our restricted visitor policy didn't work as well as it could have. Our hospital, because of how many COVID patients we were seeing, was very aggressive in shutting down the front doors of the hospital to visitors, and became problematic. We 55% of the population in Mississauga is immigrant. A lot of our patients don't speak English as a first language. And we had, in my opinion, probably an overly restrictive visitor policy. And sometimes you'd go into a room and you'd see a patient who either had cognitive issues or couldn't speak English at all. And, we were spending a lot of time on the phone with families. And I think we probably were overly restrictive out of good intention of trying to protect the hospital, but it interfered with patient care sometimes. And finally, what didn't work well, flow. Pandemics are flow killers, in case you didn't know. Pandemics kill flow. At both sites, our Mississauga site and our Credit Valley site, because of our huge volumes and inadequate physical capacity, we're super aggressive with cycling zones. Patients are in the room for 10 minutes that they're examined by an emerge doc, and then they're up and out of their rooms and into the chair, into the internal waiting rooms. And literally overnight, that became an issue and really ground to a halt. That in conjunction with the fact that although our ED volume was less, because of IPAC considerations on the floors with restricting of multi-bed rooms to just 1 or 2 people and patients instead of 3 or 4 patients, we didn't have the capacity that we could have, should have, because of restrictions on the floor. So we just, we were extremely tight in terms of flow, and we're really just coming out of that inefficiency now with bringing chairs closer together. We've ordered fiberglass, plexiglass dividers between chairs, so we can put the chairs even closer together to increase the number of patients in our internal waiting room. But our flow really ground to a halt, so didn't work very well. Lessons learned and some other general observations. Well, lesson number 1, emerge docs are people too. I have to tell you that most of my docs were extremely anxious. Those last couple of weeks in March and beginning of April. I myself, middle of March, first thing I did was to call my lawyer and update my will. Being over 60 and seeing myself as being vulnerable. I wasn't afraid to go see patients, but I recognized that, I was at risk, and I felt vulnerable myself. And so, I understood where my docs were coming from. A lot of my younger docs had small children, small babies, and were understandably anxious. And it was a big problem, and people have gotten a lot more comfortable now, but it was a serious issue. So wellness, like is the point that Mark made earlier, was a big issue for us as well. Vulnerable patients. Vulnerable patients are vulnerable. That's what we learned. The elderly, patients with addiction issues, patients who are homeless, were disproportionately affected by this pandemic. And I think it really brought home the need for us as emerge docs, as a specialty, to really advocate for those vulnerable and marginalized populations even more. We have that moral responsibility. Who knew? Public health is important. This is for my friend Kieran. You don't realize how important public health is until a pandemic comes along, and years of chronically underfunding of our public health system really came home to roost, in my opinion. So again, something else that we as emerge docs need to advocate for: a strong public health system so that we can have better surveillance, better testing, better contract tracing, and public health is important. Finally, communication. I'm not going to spend a lot of time on this, but trying to achieve the right balance between too much communication to your emerge docs and too little communication to your emerge docs was a challenge. I'm just going to make a couple of comments about just going forward. I do think we're in a much better position than we were. Our PPE situation is much better in terms of procurement. Distribution channels are much better established. There's better transparency. So there's no question that we're in a way better situation with our PPE. Our ER physicians are much more knowledgeable and are comfortable believing that the current PPE works. You put on a mask, you wash your hands, you're going to be safe for low-risk patients, and you add a shield and a gown to high-risk patients, you're going to be safe. And in general, we now know that workers, emerged frontline people who did get sick, got sick not because they didn't have proper PE, but they probably got sick from the lunchrooms and other places in the hospital. So fortunately, our emerge docs are feeling much safer than they did at the beginning of March. We've upskilled and feel safer in our ability to manage airways and manage protected code blue. Our testing capacity is greater and is going to get quicker, and we'll be able to identify positive patients earlier, and that's going to be positive going forward. And finally, of course, is the promise of the vaccine. So all in all, I think we're in a much better spot today than we were in April or May or June. And I think I'll stop there and pass it over to my friend Karen Moore.
Thanks very much, Eric and Mark, for your presentations. So I'm the odd man out. I was a emerge physician. Now I'm working full-time in public health. I just want to thank you for allowing me to speak to you today. And thank you for all the work you're doing to keep our communities safe and healthy. This statement, "Our fate is in our hands," came from the 1918 pandemic. And certainly history is repeating itself. These pandemics are all about prevention, prevention, prevention. And I do think heading into the fall, as you're seeing the numbers rise across the country, that we're having some pandemic fatigue, and that will have an effect on your practices once again. I'm going to be talking a little bit about the complexity that's facing us as well. I don't have any conflicts of interest that I'm aware of or any disclosures. I do receive research grants. I won't be talking about any pharmaceutical or vaccine product in particular. So these future scenarios of the next 1,000 days, that's what's happened in 1918, 1919, 1920. It was a 1,000-day epidemic. Certainly we hope that'll be shortened for your sake, for my sake, for our sanities, to hopefully 500 days if we get a vaccine by next summer, and that we're able to administer that it's safe and it's effective. But you'll see three scenarios here, where the first scenario is just undulating peaks and troughs of activity that through our combined efforts, through public health, case and contact management, assessment centers, rapid detection, we can control these outbreaks and limit their effects on the health of the population and of the community. The second scenario is more like what happened in 2009, where we had that spring wave, and then influenza came back and hit us hard with a high volume of patients showing up to the emergency department. But frankly, there was a low acuity in 2009. And the ideal would be what we've just gone through was our major wave in all of our provinces and territories. And now we'll have small outbreaks that will be easily controllable. That would be an ideal. In some communities, they may have that. I think in the large urban settings where you have density, where you have poverty, where you have multi-generational families, you will have undulating waves of activity that will be impacting your emergency departments. So it'll be variable across the country, and where there's good adherence to prevention strategies, your fate's in your hands, you'll see that you'll have less impact on your acute care facilities. And certainly that's what we've seen in Kingston. Our communities have embraced prevention as a strategy, and we had very small impact on the acute care sector. Although with students being back in Kingston, Queen students, St. Lawrence College, etc., who knows what's going to happen next? Just a reminder that we have outbreaks now, but they're of rhinovirus. In our daycare settings, in our school settings, we're starting to see children not attend because they've got the symptoms of rhino and they're testing positive for rhino. Those are the normal seasonal viruses that we're going to be seeing. We'll be seeing parainfluenza, metapneumovirus, the other coronaviruses circulating throughout the winter. They will be COVID mimics, and so patients may be showing up to the emergency department, hopefully to assessment centers, to primary care settings, and having the appropriate COVID testing and staying away from school and or work with these COVID mimics. But they have started. They will create anxiety. It will create a 1% of children in school settings being off and potentially needing to get tested for COVID-19. So that's already in our community. I'm sure it's across our communities in Canada already. And then it's already been mentioned about influenza. Influenza typically will be starting in late October, early November, going all the way through to March. We'll have a peak typically when primary care is not available over the winter holidays. And potentially if it's an influenza B year, it'll be over the March break where we'll have a peak. But what's going on down under right now in Australia and New Zealand, it's a dominant year, H3 and 2 dominant. And so we anticipate we'll have an H3 dominant year in Canada, but it'll be variable geographically across the country. It's not all the same virology every season. So we can anticipate that, and hopefully though, to a lesser extent, because if you're seeing what's going on in Australia right now and New Zealand, they have, and if you look at the dark blue line for Australia, they've had less patients presenting with influenza-like illness, so sudden onset of fever, chills, cough, and cold. And the same in New Zealand. They've also upped their immunization strategies. Australia was over 150% of their normal immunizations for influenza. And remember that the R naught for influenza is much less than coronavirus. It's around 1.3, 1.4. So its ability to spread is less. So if everyone's taking good prevention strategies, small social circles, good hand hygiene, public masking, we should theoretically have a good influenza season. But where you see pandemic fatigue, you will see influenza as well. And it clinically obviously won't be differentiatable for you at the clinical interface. These are some of the hints I would suggest that you get to know in your community in terms of the tabletop exercises we've done locally. If you want to know your local system's capacity, understand, will you have capacity to test in your hospital setting for influenza and or in your assessment center? Will you have any surveillance data to show when influenza is circulating? That's going to be important information. Know your assessment center, their testing strategy, what's their maximum throughput, because 1% of children in a school setting having to be often tested. Our numbers are already bumping from 200 to 300 to 400 today. And if it hits our maximum capacity, that may impact on your urgent care centers and potentially on your emergency department. And know your local public health capacity. All of these are key indicators that should be publicly available. We are to follow up every patient within 24 hours, every case, every contact. We must disclose that to the province in Ontario. And the turnaround time for the lab should be less than 24 hours. Once it gets 48 hours, 72 hours, our ability to follow up patients in a timely fashion will be diminished. And you'll see more community spread. So all of these are very important for you to monitor, to understand what's going on in your community. And oftentimes these are available on your dashboards of your local community. As well, if you're getting, these are key numbers that we're monitoring in our community of 10 cases per 100,000 per week. If you're getting higher than that, that often will put a definite impact on your assessment centers and on your hospital sector. If that is sustained above 10 to 20 to 30, you will have admissions to hospital and need intensive care capacity. Roughly in our first wave, it was around 10% of all cases needed to be admitted to hospital, and 3 to 5% of them needed intensive care settings. So key numbers to monitor is once you're above that 10, you will see a backlog in lab, a backlog in the ability of public health to follow up, and potential health system impact with increased hospitalization. So also know what the maximum number of cases your health agency in your community can tolerate. We are going to wave the flag if we see more than 50 cases in any given day. We will not have capacity. So if you imagine every case, it used to be in March and April that every case had 5, 6 contacts. In May and June, they had 6 to 10 contacts. In July and August, they've had 10, 20, 30 contacts. So the complexity of following up every case, hunting down all their contacts, minimizing the spread is becoming more complex as we get pandemic fatigue, and your public health units may not be able to have the capacity to follow up quickly, effectively, efficiently to limit the spread of this virus. And hence, as Eric has said, you really got to have good contact with your local public health and understand their capacity. And Eric's already mentioned, as well as Mark, the impact on absenteeism, on wellness, and be monitoring for outbreaks in your school settings. And for us, it's university and colleges, especially as well, that could lead to community transmission. And monitor your local public health dashboard. You can also monitor dashboards like our ACEs dashboard, which I'll get to in a second. So I've already outlined that there will be co-circulation, and this is the first time we'll be seeing patients potentially presenting with COVID and or influenza and or RSV or other viruses, and they can harbor both viruses at once. So within your hospital sector, you should be asking, do you have capacity to test with a real-time PCR? What's your turnaround time for that PCR? What's your hospital capacity for lab? For all admissions, because if we don't have good throughput, as Mark has said, we'll have patient cohorting within our hallways and the risk of transmission back to healthcare workers and or to other patients. So key is know what you're going to be able to test in the fall within your hospital sector, what their turnaround time is, and a plan for a rapid admissions of these individuals to specific cohorts. You can't or should not be mixing an influenza patient with a COVID patient. The PPE has to be separate. The staff have to be separate. They have to be not co-mingling. They should be separate wards. And certainly RSV affects the elderly, gets into long-term care facilities, can cause morbidity and mortality as well. So the complexity in the fall, I'm just trying to get that across, is increasing. Our society is trying to open, our schools are trying to get back, our colleges and universities and the economy, and there is pandemic fatigue. All of those parameters are going to have to be monitored. Public health is going to have to be monitoring. When do we slow the hospital sector down to increase your capacity? When do we slow the economy down to stop transmission? And it'll be a very dynamic situation going forward. So this is just one example of a provincial dashboard that we've created in Ontario, where we're monitoring 165 hospitals in real time. We monitor all your emergency department visits, the CTAS codes, all admissions to hospital. And on this one dashboard, we're monitoring all admissions to hospital for pneumonia. We do that traditionally every winter to give you an idea of hospital capacity, because admissions for pneumonia go up 10, 20, 30% at the peak of influenza. If it goes up concomitantly for influenza and COVID, we're in trouble. We won't have bed capacity. Long-term cares are going to also have to be cohorting patients who may have influenza separately from COVID. They won't have capacity. And all of that warning signal should be 3 to 4 weeks, that we can tell you in advance when or if both are co-circulating, or when or if we will see a higher hospital impact. So whatever province and territory you are in, try to get good surveillance data that will give you the early warning so that you can cut elective surgeries, you can increase capacity and minimize hallway medicine. And there should be spatial and temporal capacity in these tools as well. That was just a quick, John, I wanted to save time for questions given, that we're already at 8.
Well, thank you very much, Kieran, and to all of our speakers for your leadership and your great comments this evening, which were very comprehensive. We are just about out of time, and we have not yet received any questions through the online chat. So I'm going to make an executive suggestion that I'm going to offer up my email address, and if people have questions, you're welcome to email them to me. And if I can't answer them or Kylie can't answer them, we'll certainly get our expert panel's advice. And if any of them are really interesting, we can perhaps even put them out in one of the CAEP updates. So my email address, I'm very easy to find if you forget it on Google, but if you could use howard.ovens, O-V-E-N-S, howard.ovens at utoronto.ca. And I wanted to make a couple of concluding remarks, just kind of in summary. I think among the themes that emerged from all of our speakers is that teamwork and good communication is essential. So take initiative. Don't wait for your chief to do everything. Make sure that you personally are up to speed on things like donning and doffing. Organize your group to do some simulations, watch some videos on protected code blue routines and rules. Make sure everybody on your shift knows who's doing what. Perhaps if you don't have them posted, some checklists on donning and doffing are always great. Some tabletops on various scenarios, including testing overload, crowding in your ED, illness in your staff, are all good things to talk about. I think we all should be role models. It's more important than ever that we stand up publicly on social media in any way that you can to get yourself and your family vaccinated against flu. Encourage your nursing colleagues to do the same, and do that as well as supporting other public health messages and strategies in your community and on social media, including public masking, where there's been so much misinformation. I also want to give a plug. Next week at this time, there'll be another CAEP National Grand Round featuring Ken Milne and Eric Clark with an update on stroke. And Kylie and myself will be back with another panel of very distinguished guests on October 7th for part 2 on learning to surf, lessons from wave 1. As Kylie said, we'll be focusing on flow. And at that time, we'll have a bit of a more of a data slice on how the first month of fall and school opening has gone. Kylie, anybody else want to add any closing remarks?
Reach out to your local public health agency and medical officer help.
We should all be blessed to have a person like Kieran in that role, but absolutely. Okay, well, and I also want to echo Eric's remarks. Join CAEP. From all of us, good night and go Raps.
Go Raps.
Thanks, everybody.
Good night.
And that's a wrap.
Bye-bye.
And that's the wrap.
Good night.
Good night.